Hello everyone. Thank you for coming online to join me for my Caries lecture called Minimally Invasive Operative Caries Management, Take It, Leave It or Stick to It. I'm Professor Avi Banerjee and I have the great pleasure of working at King's College London Dental Institute at Guy's Hospital in the centre of London. I've been working there for nearly 30 years and you can see from the image on the screen the world's tallest dental institute standing next to Europe's tallest building, the Shard of Glass. This presentation is actually part 2 of a series that I've run on MI contemporary caries management. And my objectives of this part of the series is to define the term MI dentistry, because it is a term that is often used in the profession and often used incorrectly. And it's part of the contemporary patient-focused team-delivered oral healthcare delivery approach. I'd like to then describe and help you understand the concept of minimally invasive selective caries removal when we're talking about deeper carious cavitated lesions, and then highlight some of the contemporary alternative excavation technologies that are now available for us to use. I'd like to also take you through a little bit of a roller coaster ride of information about modern adhesive restorative materials, and then wrap it up talking about postgraduate training that is available for all of you at King's College London. So why are you here? Why are you all part of the dental oral healthcare profession? It's because we have a passion to look after our patients and try to help and prevent and manage this condition that we can see on the screen. Remember, our role as the oral healthcare team is to help the patient who belongs to this mouth. We can't prevent this, the patient has to do that. As an aside, on some of the slides you will see QR codes. Please feel free to scan these with your phones and you will be taken to websites that are relevant to the information that you are seeing on the screen. So how do we help our patients manage caries? We do it using MI dentistry. There are 2 definitions of MI. Minimum intervention care, which you can see on the screen behind me, where we are talking about individualized delivery of oral healthcare to our patients, engaging them in the process so they value and understand the care they're receiving, and linking in all the research and development we have in disease detection and diagnosis, susceptibility assessment, prevention and control, and minimally invasive operative treatments. That leads on nicely to the second definition, which is minimally invasive dentistry, a term that is more commonly understood, but perhaps, again, misrepresented. Here we're talking about selective caries removal, cutting much smaller holes, retaining more carious tissue, and then sealing it into the tooth, and allowing the dentine pulp complex to react and manage and continue in the patient. So we're really moving away from the dental surgeon's mechanistic approach of traditional caries operative management to a more biological, physiological approach with the patient in mind. So what are our aims? The aims are to start targeting care to the right patient group. We're looking at high-risk, high-susceptibility patients. We need to define which teeth we're going to intervene operatively in. Do all teeth need fillings? And the answer is simply no. And most importantly, as I've already alluded to, we need to engage with our patients. We need to be pragmatic and sensible with the care plans that we develop for them. So in that regard, we can look at an MI care plan framework, a minimum intervention care plan framework. And it's based on 4 cogs, 4 tenets behind this. You have the identify section, the prevent and control, where we use the whole oral healthcare team to give the same message to our patients. Our dental care professionals, that's DCP, oral health educators, that's OHE. We need to minimally invasively restore teeth. It's perhaps a different surgical skill set to those that we have learnt in the past in the traditional conventional approaches. And the most important glue that holds all of these beliefs together It's the recall phase. This isn't a checkup. This is recall consultation where we review the patient behavior, we review the success of any treatment we've offered, and we build in further long-term maintenance strategies. To summarize the prevention and control aspect of this minimum intervention care plan, we can argue that if lesions are non-cavitated, please treat them with a toothbrush first. Do all the non-operative preventive methods that we can see on the screen to try to arrest lesions, because these lesions can be arrested by the patient. We are now going to move on and talk about deeper carious lesions which are cavitated and need operative intervention. Now, please think back to when you were at dental school. What were you taught about operative caries removal? Many of us were taught about GV Black's cavities, class 1, class 2, class 3, so on. And we learnt to cut shapes in teeth. And into these shapes, we then placed specific restorative materials such as dental amalgam. We talked about extension for prevention and retention and resistance form. But these concepts are now outdated. We can now move to minimally invasive, selective biological caries removal, where we're thinking about the bacteria, about the biofilm, and about adhesion technology, linked with aesthetics to give a lovely end result for our patients. This is now becoming taught more and more, and I had the pleasure of taking over the co-authorship of Pickard's Guide to Minimally Invasive Operative Dentistry 2 editions ago, and this is now what is being taught in mainstream undergraduate dental schools. So, how do we achieve an optimal, minimally invasive, adhesive restoration? This is like being a circus juggler. We need to keep 3 aspects in the air running simultaneously to allow us to ultimately achieve our goal. We need to understand histology of our tissues that we're dealing with. We need to understand the complex histology of enamel, of dentine, of pulp, and how these interact, and how they change during the caries process. We need to understand our chemistry, our dental material science. We need to know what's in the bottles, what's in the compules, how they react with the tissue substrate to allow optimal sealing and bonding. And we then need to be good at our clinical handling. That we learn every day whilst we're working as dentists. We need to handle our patient, the mouth, the teeth, our instruments, moisture control, all these aspects. And that, as I said, we learn throughout our practicing lives. If we add all 3 together, we can then achieve optimal adhesive restorations. So on the screen, you can see a cavitated proximal carious lesion in a molar tooth, and you can see the equivalent radiograph there. And what's interesting is when you looked at what GV Black was talking about over 100 years ago in terms of cavity design, we ended up removing a lot more healthy tissue than we needed to, which is why we have all been taught about class 2 cavity designs. Now our understanding has improved somewhat, and we realize it's only the area of carious dentine that's within the yellow dotted outline that you can see on the screen that we're worried about. This is the caries infected dentine. This is the dentine that is necrosed. They're full of bacteria. The collagen is broken down, there's little or no mineral, and that tissue needs to be removed because it will not support a restoration overlying it. Then we've got tissue beneath that we can bond and seal to, and that allows us to retain the rest of the lesion and allows the dentine pulp complex to heal itself. So why do we excavate caries? This is a question that many of us don't ask ourselves, yet every day of our working lives, we do this whole procedure on our patients. And it's always important to reflect on these basic decisions that we make on a daily basis. So why do we do it? Is it to remove the dentine bacterial biomass, to stop the lesion from spreading through the tooth, going towards the pulp and eventually killing it? Is it to restore structure, function, aesthetic integrity to the tooth and the mouth, I think we'd all agree that's a very important part. But I would argue to you the most important reason for excavating caries is to allow us to place a good quality restoration that then maps the surface of the tooth and allows the patient then to clean that surface very, very effectively. Because it's all about the biofilm. It's all about dental plaque biofilm. That is the engine that drives the lesion through the tooth. I teach at the King's College London Dental Institute, as I mentioned, and I also work in clinical practice and have done so for many years. And in parts of London where I work, we still can see mouths represented by the image we can see on the screen, with a lot of caries there. It's still a problem. Caries has not gone away. The Global Burden of Disease study from the WHO, published 4 years ago, has ranked caries as the #1 non-communicable disease affecting humankind on the planet. So think about this. It's really quite a serious problem, and we need to understand how to manage it. If we take a representative tooth that's cavitated and we slice through it, as we can see on the image on the right-hand side, we can see the cavitated carious enamel. We can see the enamel-dentine junction mapped out. We can see the soft, wet, necrotic caries-infected dentine, and then gradually changing to the harder caries-affected dentine. This tissue still has bacteria and still has some collagen breakdown, but now this tissue is repairable. Please ignore the crisscross lines on the slide. They were actually done for a separate experiment. Now, if you were in front of me and I gave you a pen and asked you to come out and draw an outline on the screen as to where you would stop excavating this tissue, I think life would become very interesting, because we would get multiple different lines from different dentists. And I believe that's a good thing, because we're all thinking about the tissue we're removing and perhaps doing it slightly differently. Our industry partners may tend to disagree because it makes their life very difficult when they're giving us excellent adhesive restorative materials that have different potentials to stick to different types of tissue. So, I was taught 25 years ago to excavate caries to this line. And I'm sure many of you of my vintage would probably be taught the same thing. Remove all the stained tissue, clear the enamel-dentine junction, and if you have caries approaching the pulp, perhaps you can leave a little bit of stained dentine. And this dentine you leave would be quite firm and scratchy to a probe. If you've kept up to date with literature, you'll be aware the color of carious dentine is not as critical anymore. It doesn't necessarily link to the bacterial load, even at the enamel-dentine junction. And this is important because latest research in the last decade or so has shown us that we could actually be very minimally invasive. Indeed, there are studies, which we will mention later, that have sealed in all soft caries within a cavity and literally put a lid, a cork on the top of the cavity and sealed everything in. And these have shown very, very promising results. I am not suggesting that tomorrow when you go into practice that you should necessarily do that, because as I mentioned, that soft, wet, necrotic dentine will not really support a restoration very well. A little bit like thinking of walking on a sheet of glass that was placed on a mattress, a bed mattress. As you walk on it, the mattress would flex, the glass would break. And that's what potentially can happen to your restorations. So we need to look at some of the evidence. We only have a short time in this webinar, so I'm only going to select certain references and papers that I just want to highlight briefly. And this is one of them, run by a very good bunch of authors, with Lars Bjorndal as the head chief author here, which was published 7 years ago, but an excellent clinical study. There's a lot of information on the screen there, and I'm really only putting that up to highlight that this was a very carefully controlled clinical trial. And these are very difficult to do in real life. But one group had selective caries removal, others had complete caries removal. And they analyzed the rate of pulp exposure and pulp death, etc., etc. And essentially, they found the less deep you excavate, the more chance there is for the pulp to survive. It's quite a simple conclusion, but a very, very important one. So arguably the best pulp protection material is dentine, not any restorative materials that we place. We also have systematic reviews that are available to help us ascertain and look at all the evidence so far and try to pull it all together. One has to think carefully about systematic reviews and their outcomes because they can be a little bit skewed from time to time. In the first one that was published several years ago, only 4 papers were included in the review. And now this has been updated more recently with a second systematic review that was published about 4 years ago. And in that, they concluded that there wasn't a problem with incomplete or selective caries removal. In fact, pulps liked it. Pulps survived, as did the restorations that were placed in those cavities. And you can see that more up-to-date reference in the bottom left-hand corner there. And there are other papers that have been published that show the same thing. So the evidence is most definitely building. One of the often quoted papers that triggered this whole concept of selective caries removal were the studies published by Ava Metz-Fairhurst back in 1998, where she and her team ran a 10-year prospective trial where they sealed in caries and used adhesive restorations to literally put a lid on the lesions. These patients were reviewed regularly and their oral hygiene was good and they understood their treatment. And over time, you can see from the data, the sealed restorations actually survived very well. And they retained all the caries in those teeth. Nothing was removed. They just sealed to sound enamel margins. And this was a very compelling study and has been corroborated by many other studies since. So in summary, we've got to think about what tissue we're removing, to what depth. We need to think about the histology. And if we make an average, I would argue that most dentists nowadays are removing caries to the red line you can see on the screen. Perhaps all we need to do is remove to around the blue line, so much less. But we have a problem. And the problem is, I am showing you cross-sections through lesions, which allow us to see the histological change nicely and clearly. When you are eyeballing a tooth in a patient's mouth, you are getting a very different view. And it's much harder to find this transition zone between the infected and affected dentine that you might want to retain. And at the moment, we use our sharp dental explorer and we drag it across the tissue and we feel for the sensations of stickiness and softness and we listen to scratching sounds. It does sound primitive, but at the moment, really, that's all we have to help us. So using careful caries excavation methods is really quite important. And we're going to come to that shortly. So in summary, we need to think about the patient when we're going to operatively intervene in caries management. We need to think about the histology, as I said. We need to think about the margins of the cavities that we're going to restore. The enamel margins, the dentine margins. Is it sound dentine? Is it caries affected dentine? The pulp proximity, all these factors. And then consider the chemistry of our restorative material and the adhesion ability and the bonding ability. So let's move on to looking at some of the clinical excavation technologies that are available. There are many out there. All of us use dental burs, carbon steel, diamond, tungsten carbide, plastic burs even. There are mechanical non-rotary techniques, hand excavation, air abrasion, etc. We've got chemomechanical methods, Caridex, Carisolve. In South America, there's Papacari. And there's also lasers and photoactive disinfection, ozone, and many other technologies. We fortunately do not have time today to go through all of these, so I want to pick out one or two, which are rather interesting. Carisolve gel has been around on the market for nearly 20 years. And the idea is that it uses chloramine technology to soften already broken down caries to allow you to literally whisk it out of the cavities. So here you can see a buccal cervical cavity in a lower right canine, large carious lesion, and the Carisolve is already placed within the cavity. Carisolve is manufactured by a Swedish company called RLS, and here you can see a little video clip, obviously on an extracted tooth, showing you the technique that is used. You use non-cutting instruments, abrasive instruments, to whisk inside the cavity and actually emulsify the caries out into the gel. You'll see now the image on the left has changed, and you can see how the caries is now emulsified out. And it actually allows you, with tactile feedback, to be quite careful and selective with the tissues that you're removing. We can see the end point of excavation here in that same tooth. And many of you will be looking at that cavity and gasping, thinking, why has he left so much caries, especially in areas like this? Of course, that dentine where my arrow is soft and wet. I am not going to lie to you. But the enamel margin is actually sound. I appreciate on the image it does look a little bit frosty. That is because I've taken a gingival margin trimmer and an enamel chisel around that surface to make sure that it was hard and solid. I then restored that tooth at that level. Many of you will have been taught to excavate that caries down to sound tissues at the enamel dentine junction, quite rightly. But if I'd done that in this tooth, the margin would have been about 3 millimeters subgingival, and that tooth then becomes unrestorable. And this is what I mean by going back to the slide where I showed the triangle with the 3 different beliefs, the 3 different factors, and you have to balance out your histology with your chemistry, with your clinical handling. We can see hand excavation here and how that will tend to allow you to over-prepare excavation of cavities. I've mentioned Carisolve, and actually 3M did develop an experimental gel of their own using pepsin as a method of excavation. If you noticed on the screen, that instrument is plastic, but again is abrasive. And that instrument, the plastic that it's made from, is relatively the same hardness as the tissue it's trying to remove. So again, if you over-excavate, it will blunt. As you get closer to the pulp, you can start to use a nylon brush, perhaps, to actually have really selective removal of tissue that you don't want overlying the biological tissue that you want to remain in the cavity. This is experimental, but it shows you how companies are really investigating this type of technology. So what about burs? We use dental burs every single day of our working lives. And do we understand how they work? And this is very important because you are attacking, dare I say, your patients with these instruments every day. And it's our job and our duty to understand exactly how they work. We can see with clever video microscopy that was pioneered and carried out in our labs at King's College London at Guy's many years ago by Professor Tim Watson and his team, some really excellent close-up histological footage of how burs cut teeth. So you're about to see a video clip of a diamond burr cutting enamel. You will see the enamel coming down the screen, and you will see individual prisms of enamel. And if you remember back to your dental anatomy days, each prism is approximately 4 to 5 microns in diameter. So you can get the scale that you're looking at. So let's see what happens. So you can see the enamel dropping down the screen, and you can see the cutting surface. The video stopped. It will start again, and you'll see a bright flash on the bottom left-hand corner. That's an individual grit of diamond passing in front of the objective of the microscope. And if you look at that cut surface, you can see now it isn't cut. It's chipped, smashed, shredded, torn, every other verb you can think of, but it's not cut. If we look at a representative tungsten carbide burr and what it does to enamel, you can see how clumps of prisms have been ripped out, how they've been separated, how there's clefts and cracking running all the way through into the enamel. So that's the sort of collateral damage that occurs when we cut teeth. Now, in the good old days, in conventional operative management, we would place a dental amalgam into this cavity. And that amalgam would push up against these tissues, and the low copper amalgams would then corrode over time and actually fill in some of these defects. Nowadays, we're using adhesive technology more and more. You may be aware of the Minamata Treaty, which was activated in mid-August of 2017, and there are now, I think, to date, 85 countries signed up, which essentially means dental amalgam use will be gradually phased out over years in many different countries. So we will be having to use adhesive biomaterials. And we know that all our biomaterials shrink when you set them, when you cure them. And when they shrink, they pull. And they will pull on the natural tissues and actually accentuate these defects and cause more damage. And I will show you the effect of that a little bit later. So let us look at what alternatives we have to cutting teeth without causing this intrinsic tissue damage. Here we can see wet alumina air abrasion. And you have 3 videos running concurrently showing the clinical cutting on the left, the histological cutting in the middle, and the microscopic histology on the right. And the beauty of air abrasion is you're getting small particles of aluminium oxide, which are essentially exploding onto the tooth surface with the kinetic energy and causing microchipping on the surface. But you don't get the same cracking effect through the tissues. We have done a lot of research at King's and in our research division looking at what other powders that we might be able to use that may be more selective for caries removal. And over the last 10, 15 years, with multiple PhD students and master's students and postdocs, we've looked at developing bioactive glasses. These are human-made silicate-based glasses. They're already used in the human body. And the clever bit about them is that in a biological aqueous environment, these glass particles start to develop hydroxycarbonate apatite on their surface. So there is a type of osseointegration, if you like. I use that term carefully, however. But by doing this, and by altering the particle size and the shape and the hardness, we can change their cutting properties. And so we've investigated the use of bioactive glass as an air abrasion powder. So here we have a tooth with a dubious central fissure in terms of caries. We could extract the tooth. We could put it under a scanning electron microscope and have a look at an image there, but you know what? That's not really helping us very much. So we can use bioactive glass air abrasion, and you can see the manufacturer's details there on the screen. And we have a little video here showing this air abrasion dry, but this is bioactive glass particles. And if you look closely, you can see that when the jet is directed onto healthy tooth surface, all it is doing is removing the stain on that surface. It is not cutting. When we direct it into the fissure, we can see the fissure is actually gradually being opened up. And at the end, we can see the final tooth, and we can see how that fissure has been opened up. This is because the enamel was demineralized, and it was demineralized down to the level of the enamel-dentine junction. And this is an important point because the remaining enamel, which is sound, has not been affected. Remember the scale of this. That fissure is still no wider than a periodontal probe. And you now have a surface that's very conducive for sealant restorations after acid etch. So I am not saying that we should be cutting early enamel lesions. That's not the take-home message here. But what you have is a system which allows you to clean teeth, and in a high-risk patient where non-operative prevention hasn't really worked, this may be a suitable treatment option. On the right, you can see a healthy extracted premolar. No caries. If I air abraded that with aluminium oxide for 2 minutes or 112 seconds continuously, there would be no tooth structure left on that surface. If I took a burr on that surface for 112 seconds, there would be no tooth structure. If I take silk, that's the bioactive glass, you look at the image, all that happens is the tooth is cleaned. So it is not cutting sound enamel. So this is really quite interesting and exciting. And you can see it in use here in a patient to remove stain. Note there's no rubber dam. The study we published in 2010 showed that the stain removal was very effective and desensitization of dentine was also very effective, more effective than sodium bicarbonate. So this is also a potential use for this technology. So, in summary of these excavation technologies, it would be great to have instruments that helped us distinguish between sound tissue, affected tissue, and infected tissue, and also at the same time be self-limiting, reproducible and reliable, and leave histology that allowed us to optimize our bonding and adhesion. And of course, we want them to be cheap, easy to use and maintain. So I hope our industry partners are listening. So we now move on to the third part of this presentation I mentioned to you at the beginning, where we're going to start looking at the restorative component. So we've looked at how much caries should we remove. We've glanced at what some of the technologies are that are available for us to do this minimally invasively. And now we're going to look briefly at some of the restorative materials. Are there materials nowadays that adhere to, seal, and even heal carious tissue after we have done selective caries removal in deep cavitated lesions? And guess what? There are. So let's have a look. We are talking about deep lesions close to the pulp. Remember that. So we're talking about pulp protection materials. We used to call them pulp capping materials. And in ancient history, we called them lining materials. I haven't used that terminology in my textbook for the last 10 years because we need to move forwards. And you'll see why as we're talking. So if you think about direct and indirect pulp capping, we classically have used formulations of setting calcium hydroxide for many years. And indeed, we are still teaching the use of this in direct pulp capping when the pulp has been exposed, unfortunately. But it's not necessary for indirect pulp capping anymore. I put in zinc oxide eugenol for historical reasons. We really don't go down that avenue anymore. Glass ionomer cements are very effective. And Tom Hilton published an excellent critical review paper back in 2009 in Operative Dentistry, where he looked at several hundred papers and picked out all the information and showed that if you are choosing to place a deep amalgam restoration in a large cavity close to the pulp, if you're going to place some pulp protection, think about using a glass ionomer cement. We can place flowable resin composites in deep cavities. One of the issues about resin composites in deep cavities was the issue of post-operative sensitivity. People have shown that is created a lot by leaving porosities and voids at the base of the restoration. By using a flowable composite, those voids are eliminated. The older flowable resins shrank a great deal. More modern flowable composites don't shrink so much. So these problems are being overcome by our industry partners. We can bond directly to caries affected dentine, and we'll talk about this case in a little while. We can use mineralized trioxide aggregate materials, calcium silicate materials, and these have been developed by Septodont into a restorative material called biodentine. And this is a very interesting material because it's one that produces lots of calcium hydroxide and lots of good remineralizing ions and a very alkaline pH that will kill off bacteria. And it's very different from all the other restorative materials we've got. It's not a replacement for glass ionomer or for resin composite. It's another material we can use to try to keep pulps alive in deep cavities. And you can see images where the mineral is precipitated at the surface of the dentine into a mineral interaction zone, or MIZ. And we can see that here on the scanning electron microscope image, where we can see fresh crystals of hydroxyapatite having been deposited on that dentine surface. And those crystals have come from the biodentine chemistry. Indeed, 2 years ago, one of my excellent PhD students, Danya Hashem, completed a clinical trial where we took patients who attended the clinics at King's College London at Guy's with large carious cavitated lesions, but whose pulps were still alive. The pulps were still vital, and we used all the clinical techniques and radiographs and cone beam CT also. You can see one such example on the screen as the lesion presented, and after caries excavation using Carisolve to try to have some minimally invasive selective tissue endpoint. The biodentine is in place, and then a month later, this was veneered, the surface was refurbished with resin composite, and then reviewed at 6 months, and then at 12 months, where further investigations, radiographs were taken. And this highlights a really interesting point about minimally invasive dentistry. If we're going to leave more carious tissue behind in cavities and being more selective, one of the problems we're going to find is the fact we're going to get shadows under our restorations. And this is a no-no in conventional, traditional caries management. Here we can see another example at T0 and presentation with a large carious lesion on this upper first molar. And a year later, with the restoration in place, we can see that shadow. And this throws up a real clinical conundrum. Because if this patient leaves your practice and goes and works for somebody else, and they take this radiograph and they see this shadow, what are you going to think is the problem? Is that shadow active recurrent caries? Is it residual inactive caries that's been purposely retained? Is it a leakage defect? Is it another pulp protection material that's radiolucent? Or might it even be a material effect, a restorative material effect on the dentine itself? And again, the whole point of this slide is to warn you that you are not treating radiographs. You're treating the patient. So you need to go back and do full clinical examination and a history of pain and everything else and work out whether you need to go back in there to restore it. And often you will find you will not need to. So please beware of this. If we look now at bonding and sealing to caries, we're going to have dental adhesives, and there are many, many, many different adhesives on the market, and there's new ones coming out every single day. And they're very effective, and they've improved considerably over the years. It is important that we, as the operators, understand the chemistry of these adhesives, and the chemistry is rather complicated, I'm afraid to say. So we can try to simplify it a bit with this little table. There are 4 types of bonding systems, often known as generations. The 4th generation is actually the type 1, where you etch your tooth surface, you put a separate primer on that tooth surface that will link your dry composite to wet collagen in the dentine. And then you have the bond, which is then the coupling for the restorative material on top. And you can see some names of some of the market leaders in the field. This slide is not here to promote one product over another, but just to give you an awareness of what's out there. And for many, many years, these type 1, 4th generation bonding systems have been the gold standard in terms of adhesion. We've got etch and rinse adhesives, type 2s, where you acid etch your enamel or dentine with 37% orthophosphoric acid for 20 seconds on enamel, 15 seconds on dentine. You wash off the acid etch carefully, you don't over dry the dentine, and then the prime and bond components go on together. And again, you can see some names of successful, good quality materials. In the Far East, people realized that really you don't want to be putting strong acid etch onto dentine, so they built in more mild self-etching systems. So the primer chemistry contained milder etchants, but they're still a 2-bottle system. And nowadays we have the all-in-one systems, where components might be mixed initially, but it's one application onto the tooth. And usually these are stronger systems that will allow a little bit more etching on the enamel and the dentine. And the universal bonds now are really clever, and many companies, including 3M, are producing very successful adhesives that can be used in multiple different ways. This allows us, as clinicians, not to have to buy 4 or 5 different types of adhesive, but we need to understand the chemistry and the clinical skills behind using them. This is data taken from Bart van Meerbeek's paper published 7 years ago, a little bit old now, but you can see it's looking at clinical data from 1998 to 2009. And you can see how the bonding ability and the seal ability of our adhesives is improving so quickly. So we're getting better and better materials. So I think the days of complaining about our materials are long gone. In this BDJ article that's listed on the bottom of the screen, you can follow this clinical treatment protocol of how we manage the enamel, the carious dentine, the acid etching, the priming and bonding of the surface, and then the incremental buildup of the occlusal composite restoration. But it will show you that you can successfully restore very deep caries very effectively, and as you can see, reasonably aesthetically. When you start looking at experiments in terms of the bonding strengths of restorations to caries-affected dentine, we published some data several years ago now where we looked at some of the 3M products and others and bonded them into carious teeth and also into sound equivalent dentine. And we did microtensile testing, which is a laboratory-based testing method that can be used all around the world in different laboratories, so it allows a little bit of comparison. It's not a perfect simulation of what happens in the mouth, but it's the best that we have at the moment. And what we found in the samples we looked at is that bonding to caries-affected dentine and sound dentine alike, we were getting bond strengths on average around 25 megapascals. Now, I am looking at you all virtually down the camera, and I can see you all looking completely deadpan and not bothered about that last statement. And you know what? I don't blame you. Because what does 25 megapascals mean to you or I? It's just a number. However, if I tell you that to take enamel off dentine at the enamel-dentine junction, if you were trying to literally unzip, peel off the enamel, that natural bond in the tooth has a bond strength of approximately 48, 49 megapascals. So in our studies, we were getting a bond strength to caries that was half the natural bond strength to a tooth. And trust me, there are plenty of other papers out there with even better bond strengths than ours. So we're now bonding to caries, yet we're getting the strength at nearly half the strength of the natural tooth. So this is exciting, because do we need any more strength? Because we have problems otherwise. Look at glass ionomer cements. Think about the complex setting reaction, the acid-base reaction. Think about the ionic exchange. This is stuff you may well have to go back to a textbook and check over. You did know this stuff once, and it's very important that you do now if you're going to use these materials. Very, very effective. They bind to calcium ions. And here we can see some really interesting studies where the glass ionomer, in the video clip you can see on a loop, the glass ionomer is on the left. And you can see how we forced it to shrink. We've dehydrated it on purpose within a cavity and forced it to shrink. And where the blue arrow is, look what it's doing to the enamel. It's actually pulling the enamel apart. If you look on the right-hand image, obviously the still image, the glass ionomer is on the left, the enamel E is on the right, and look where the crack has happened. It's happened within the enamel. Many of us were taught that it was the interface between the restoration and the tooth that would fail. Nowadays, that interface is actually quite solid. And because we're chipping our teeth and cracking and fracturing our teeth, we're actually getting failure, cohesive failure within tooth structure. And that bothers me, because there is no restorative material that is as good as enamel, dentine, or pulp. My first paper I ever published with Professor Tim Watson was, the work was carried out when I was a third-year dental student at Guy's, as it was then. And I used to sit in the laboratories on floor 26 with Prof. Watson over weekends in the middle of my medical surgical pharmacology exams, I remember distinctly, and we were looking at how we might protect the surfaces of glass ionomers, because we realized and we knew then that the water flux through the glass ionomer as it was setting was critical in the outcome and the success and the resilience of the final restoration. So my first paper I published was looking at that surface protection with resin coatings. And what's interesting is around 20 years later, 25 years later, the manufacturers are producing high-quality GICs with resin coatings to improve the resilience. And when you look at some of our internal data that we've done with one of my PhD students, Lamis Altai, we found data to start showing that a lot of the glass ionomers that are available on the market now are really quite effective in terms of their hardness, in aging after a month in terms of their fluoride release. So we're getting really good quality materials. Now, this throws up an interesting conundrum, because in the past, glass ionomers have not been accepted as a definitive posterior restoration. I think we're coming to a time now where they may well be considered a definitive posterior restoration. And this is a case done by Duvi Raju, one of the MSc students on my master's program that I'll talk about a bit later. And we had a leaking amalgam with lots of caries, which was excavated minimally invasively. There was the cavity in the middle image there. You had conditioning with polyacrylic acid. The cavity was dried carefully but kept moist, because you need that for the glass ionomer to bond. And then this glass ionomer, which is actually Equia Forte from GC in this case, was placed, and then the resin coating placed. And there is evidence building that these restorations, even in occlusion, are lasting a matter of years rather than months. They will need refurbishing, no question, no debate. But that's not a problem. That can still be defined as a posterior definitive restoration. Here we see 3M's Keytac Universal glass ionomer restorative. Same sort of thing, being placed. It's a relatively simple technique. It can be used in children, in adults, and it can have a very effective and successful outcome. So coming to the end of the presentation, we need to think about the longevity of our teeth. And that's the most important thing. I'm less worried about the longevity of our restorations, because restorations can be replaced and they can be fixed. Teeth can't. So always consider the failing tooth restoration complex and think about how they could fail. The reasons are coming up on the left of the screen. It's all very obvious. Caries, pain, plaque stagnation, aesthetics, and fracture. Those are the reasons why a tooth restoration complex will fail. And we then need to think minimally invasively of how we're going to manage this condition. And you can manage it using the 5 R's. Reviewing the tooth restoration complex, the patient, refurbishing surfaces, resealing margins, repairing defects and fractures, and then ultimately replacing restorations fully. So let me quickly talk you through this. There are publications there at the bottom of the screen that highlight all the detailed protocols. So if you look at reviewing, this is where clinical photography is so important. If you look at the 9-year image there, on its own, many dentists would restore that. If you see how the restoration has changed over time, there is nothing really wrong with that restoration. If you look at the image on the left, many young dentists would restore that, take the filling out and replace it. All it needs is a surface polish. We can reseal defective margins, whether they're adhesive restorations or amalgam. We can repair defective portions. And I repeat again, all the detailed protocols are in those papers and publications at the bottom of the screen. And of course, ultimately, we are going to have to replace restorations. So again, the key message is to think about the looking at the list there and deciding when to come in. Think of minimally invasive dentistry. Don't always go to the end of that list. So in summary, we need to identify a patient's caries risk, looking at the oral hygiene, diet, fluoride, etc., and think about non-operative prevention. That was the topic of part 1 in this series of lectures. We then want to be looking at the signs, the symptoms, the anatomy, the pulp status, restorability of the teeth, the activity of the lesion, the level of cavitation, and then we make a decision as to how much caries we excavate. There isn't a right and a wrong way of doing it, but what we need to do is the correct way for that tooth in that patient. So there's got to be biological, chemical, and operative justification. We need to then choose the right materials, the right techniques to do this in a minimally invasive way. We have to take the patient along with us on this journey. This is the whole point about minimum intervention dentistry. It's that partnership that the oral healthcare team has with the patient. We need to write careful reports of all the investigations we take, radiographs, etc. As I mentioned already, we need to justify all the decisions we make, both operative and non-operative, and write good quality contemporaneous notes either on electronic systems or handwritten. I think clinical photography is going to be essential in the future, and I'd like you just to look at this little video clip as a summary of a BDJ issue that will provide you with the evidence of what I've talked about. Minimum intervention oral health care is a contemporary approach to managing oral disease, and in this case specifically dental caries, and maintaining oral health in our patients. We're using the full oral healthcare team to deliver this approach, and it is very much patient-focused, working on the relationship with the patient to get them to understand their disease condition and how to manage it and prevent it. I have been fortunate enough to gain the expertise from 10 different national and international experts in the field of MI dentistry who produced papers for this issue. These are all useful for every member of the dental team and will cover topics ranging from risk assessment and patient behavior management through to remineralization technologies for early lesions, selective caries removal protocols and minimally invasive techniques to do this, managing the child and older patient in an MI way, and also developing your business practice and also the medical legal aspects. I hope you find this issue interesting, and thank you for listening. So as you heard, this themed issue has collated together papers that will help provide evidence to back up all the things I've touched upon in this presentation. And please don't hesitate to scan the QR code on the screen, which will take you directly to the web pages that are relevant. I mentioned as my final objective at the beginning of the presentation, talking about postgraduate education in MI dentistry. And I put together a master's program at King's College London Dental Institute about 5 or 6 years ago that I wanted to teach interested dentists about all the different aspects we've touched on today in terms of minimum intervention care and minimally invasive dentistry. To really emphasize the paradigm shift, moving away from the procedure-driven traditional management techniques to the more care-driven contemporary approaches of MI. To look at the latest materials, cutting-edge diagnostic, preventive technologies, all MI surgical skill sets, which are perhaps a little bit different to what many of us learnt at dental school. I've also put into the program business planning, workforce management, and medico-legal issues and ethics, law and ethics, to try to build implementation into the training. The evidence is out there, but we now need to try to do MI dentistry in real life practice. And this is what the master's program hopefully will enable people to do. It is open to practicing dentists and therapists globally. And ultimately, we need to enjoy what we do in our profession. And I think that's very critical. And I'd like to show you a brief testimonial about the MSc in Advanced Minimum Intervention Dentistry.
Minimal intervention dentistry is about treating the whole person, interacting with the individual and building real relationships so that they maintain oral and dental health throughout their lifetime. That's the reason why I chose AMID at King's.
I think the next step in prevention would be minimum intervention. It's how to actually do something in a simpler way, cost effective for the dentist, but also for the patient. And I think Abby's program has actually exploited that to the core, and it's brought it out to the forefront. And I think it's a wonderful, wonderful way of actually learning dentistry and also actually benefiting from it.
AMID's program, it's what I have been done for years, not actually knowing that I'm doing minimal intervention, so I can be able to do what I do with academic or basic support.
I think postgraduate education is a must in the modern world. And I think MI dentistry is becoming a specialism in itself, and really thought that was a good way to go.
Well, the best things about the programme is the staff. They are fantastic. They are well renowned, and everyone who is a dentist in the UK will know the names of the people who are involved in this course.
We've had chances to meet important figures in the dental world. We've been doing a proper clinical trial for our thesis rather than a literature review. I think I've really come forward in ways I didn't expect.
The support you get from Professor Banerjee at the top all the way through all the staff, it takes the stress out of learning a distance learning course because it is done out of hours. You still do your normal job on a day-to-day basis. It's almost as if you are a student in King's.
There's no doubt it is hard work, but it's ultimately rewarding. I'm year 2 now, and I'm thoroughly enjoying it. I'm living in the moment, so it's great.
We were drawn to Professor Avi Banerjee and the work that he was doing in this area, and we thought he was truly inspirational. So when the opportunity came about to support the AMID program at King's, which is a recognised world leader in dental healthcare and dental healthcare education, it was a no-brainer for us. We wanted to support this program. Minimal intervention dentistry to us is the completely transformational change of dentistry.
The future is really exciting, I feel. We want to preserve and protect teeth, not take them out, and that gives us no pleasure. So that's really where I feel that the AMID course can bring me, and I'm glad I did it at such an early part of my career.
I want to pursue with my PhD, and AMID is completely supporting my futuristic aim because we're doing a lot of research. We've been exposed to the research methodologies. This is going to be a platform or a foundation for me to build my academic career further on.
I'm going to set up a minimal intervention dental centre. The other thing I'd like to do is set up study groups so that we can sort of spread the message of minimal intervention dentistry locally. AMID is the foundation for how I'm going to take my whole practice and the rest of my professional career from this moment onwards. So without AMID, it'd be a normal, routine, run-of-the-mill dentist, which doesn't appeal to me at all.
There were up to 100 dental operations per day involving dental clearance. The principles that AMID represents is the answer to the problem. So as far as I'm concerned, AMID is the future.
So all that's left for me to do is to thank you very much for giving up your time to listen to this presentation. And I hope you get a chance to listen to part 1 also to tie the two together. And I hope I've whetted your appetite to find out more about MI dentistry and the transformational change in oral healthcare delivery that we can offer our patients in the future. Thank you so much for your attention.